in the ICFs, intermediate care facilities for individuals with IDD. Next slide. The House's version of this is a little bit different. There's 33.9 in the first year of the budget and 68.1 in the second year of the budget to increase direct care worker wages for all CVS providers. There's a typo there. And then 17.5 million in FY 2022 and 21.8 million in 22-23 for a wage increase for direct care workers employed by ICFs. So I think the big issue there are not so much the issue, just kind of what we're going to have to wait and see what happens. The state is proposing using some of the money coming from the American Rescue Plan. And that really is kind of initially intended to be some one-time money, one-time funds, what you would hear referred to as non-recurring. These are obviously recurring expenditures for our state. So trying to determine how the funding will work in terms of recurring and non-recurring to support this. Next slide. And this is the strengthen the North Carolina's behavioral health safety net and increasing healthcare coverage across the state. So I think it's important to note that neither version of the budget, neither the House's version nor the Senate's version, include true Medicaid expansion, as the Governor Cooper has been really pushing for during his term. So it's obviously important and something that we want to see, but that's neither of those versions contain what he would say is true Medicaid expansion. In terms of the state single stream funding, there are the Senate's version of that would reduce the total single stream funds by 5.4 million each year. And then the House has no additional single stream reduction. So this is, it is better in terms of some of the reductions that you all know that have impacted on the state side or the single stream side in the past several budget cycles. And then also regarding this, there's a $30 million transfer if to the state single stream funds, if the state has a Medicaid budget surplus annually. That's what's been proposed in the budgets. Next slide. And again, last but not least, an investment in new innovations waiver slots. You all are fully aware that there are more folks waiting for waiver slots than there are active waiver slots in our state. We were happy to see that both the Senate and the House versions of the budget add 1,000 innovations waiver slots. They would be allocated over the biennium. So we get a certain number of slots in year one and then a certain number of slots in year two. So again, it's not certainly enough that's going to bring everybody off the registry of unmet needs. So the other thing is that both budgets would authorize the department to consider pursuing a tiered waiver if that would be a way for the department to look at bringing additional folks off the wait list a little bit faster. So I will kick it over to Brian, and we are going to switch gears and talk about the LME-MCO realignment, and we'll take questions for both of these portions at the end.
Thank you, Sarah, and good afternoon, everyone. My name is Brian Perkins. I'm Senior Vice President of Strategy and Government Relations for Alliance. And just to reiterate, as Sarah mentioned at the budget, so we felt it was important to kind of showcase, as Sarah mentioned, those key items of where they stood in each the House and Senate budget, because as Sarah mentioned at the top of the presentation, that process is we're hoping will conclude soon, and that budget will go to Governor Cooper for his kind of informal feedback with the goal of hopefully getting something that can be agreed upon among the General Assembly leaders, the governor. But again, we try to update you on what we know. And I think by pointing out what's in each of the House measure and the Senate measure, we're thinking that the compromise, when that appears, the numbers will be somewhere around there. So we wanted you all to have those parameters. So moving to county LME-MCO realignments, as you know, over the past few months, several counties in North Carolina have effectuated their right to to change LMMCOs, or what they call disengage and move from the LMMCO they were with and realign with other LMMCOs. And for Alliance, that meant that we will be that Mecklenburg County and Orange have each elected to realign with Alliance Health. And on August 6th, so the way this works is the counties essentially put together an official ask that goes to the North Carolina Department of Health and Human Services. And both Orange and Mecklenburg, as well as the other counties in the state, as well as other counties in the state, had submitted those requests. And on August 6th, DHHS approved those requests. So essentially green lighted those realignments. So what that means for us is Mecklenburg and Orange moved from the phase where they were asking for realignment to actually that being approved and moving towards the implementation phase of these realignments. So them coming into the Alliance service area. So the effective date for those realignments is December 15th of this year, December 15th, 2021. And that's according to the timetable that DHHS has established. So again, that's a pretty expedited timeline. So, our transition planning for that has been underway and is well underway. And I'll detail that more for you in a moment. Next slide, please. So there, just to give you a broad overview, there is Sarah mentioned a little bit about Medicaid transformation and Alliance becoming a tailored plan next year. These are the regions for the tailored plan that show where the counties have realigned or will realign. So that the purple or pinkish, it represents those Alliance counties. So you'll see Mecklenburg and Orange being added to that map. Next slide, please. So again, with this, our top line goal with these transitions is to ensure as seamless as possible a transition for members and providers. So again, we're taking because of the speed at which these realignments are happening, we're essentially looking at it in two phases. And that initial phase is to ensure the seamless transition. And that's again to make every effort to make sure we honor all existing service authorizations for members. We contract with existing providers that are good standing. Those meetings are going on right now in terms with Kathy and her team having direct interaction with providers in Mecklenburg County, for example, and also maintaining provider rates. And essentially, this process allows us to we're engaged with Cardinal and the department in a number of regular meetings in terms of getting the information we need in order to effectuate these realignments. And part of that, for example, with provider rates, is getting the information from Cardinal about what providers are being paid. And essentially, that's an ongoing process that we're in the midst of doing right now. So as we get that information, we'll be able to make more definitive decisions about provider rates. But again, our bottom line understanding going into this is to make sure that we ensure a seamless transition by doing everything we can to honor existing authorizations, contract with providers, and maintain provider rates. Next slide. So again, part of the activities we have ongoing, as you might expect, bringing on these new counties, we are in a growth mode. Alliance is scaling up operations. If you or any of your stakeholders are interested, we are hiring over 450 staff that will, as a result of the realignments and also as a result of planning to become a tailored plan. So if we have a website, Careers at Alliance webpage on our Alliance website that lists all those positions, all those postings. So again, we're getting thousands of applications right now. I think last I heard we had 3,200 applications in the process, and those are applications that are not necessarily individuals, because folks might be applying for multiple positions. But again, that's something that we are in the scale up phase right now. Also, we're preparing physical office spaces in both Mecklenburg and Orange. We're going to have a physical presence in both counties. So we'll have people working on the ground in each of those counties. And we'll also have people working in a hybrid function and some remote workers as well. So again, as COVID has showed us, we a number of fronts, but there will be an on the ground presence in each of the new counties. We're meeting with local stakeholders and community partners. And that involves ongoing meetings with the DSS offices, for example, from both counties, from Orange and Mecklenburg, having a number of different stakeholder meetings. For Orange, we had a series of virtual town hall meetings with the public and with community member advocates. And in Mecklenburg, we're doing something similar where we're having stakeholder group meetings. So again, our key to doing these realignments is doing what we do well in our current communities, which is fostering and utilizing community partnerships within our service areas. So we're looking to build those out as well. And as I mentioned, we're engaged in regular meetings with Cardinal and the department about gathering the data we need the things we need to know in order to be ready to go on December 15th when our realignments are effective. And again, as I mentioned, we're in the process of meeting with providers right now, interacting with providers directly about filling out enrollment packets and doing other things. For example, our members of our provider network team were on the ground recently in Charlotte, meeting directly with providers that are interested in coming into the Alliance network. And again, those meetings are happening both in person and virtually to make sure we're getting as much coverage as possible. Next slide. And finally, as I mentioned with utilizing community partnerships, is we want to support local voices in our communities, just as we do in our current communities. So that involves bringing representatives from Mecklenburg and Orange into the Alliance CFAC, setting up provider advisories committees for Mecklenburg and Orange that will then filter up to our all provider meetings and other avenues such as this. Setting up community directors meetings, which are essentially regular meetings of HHS stakeholders in each county, setting those up in Mecklenburg and Orange, and doing our regular all provider meetings and learning collaboratives, incorporating members of the public and particularly our providers like we're doing today. So next slide. And I think that concludes Sarah and my presentation. Kathy, did we say want to take some time for questions?
Yeah. Let's go ahead and see. So Kathy, there's two Kathys, just so we like to confuse you guys. Sorry about that. But Kathy Stevenson, are there any questions?
There are no questions so far.
Okay. All right.
Thank you.
And if folks again have questions for the chat, we can look at that at the end. So we'll go ahead to Christine Gillenkirk, and she's going to talk about comprehensive care management assessment.
Thank you, Kathy.
You're welcome.
And yes, I am Chris Gillenkirk. I'm the Director of Community Care Management here at Alliance. And myself, along with a number of other leaders throughout the department, are working towards our build for the comprehensive care management assessment that will be a part of our tailored plan implementation, and building that within our current electronic medical record platform, Jiva. Next slide. And so really, this is just an opportunity to share what is being conducted with Zomega, the service who oversees Jiva, the technology company, and answer any questions that any of you have regarding the progress or content to this point. It's going to be a very high level overview of the build of the assessment because it is quite extensive in what it will do to assess our members going forward. Next slide. So we refer to it as the CMCA, which is the Care Management Comprehensive Assessment. It's going to have two options for lines of questions to complete, which are specific to age groups. They will be divided between adult and child. Within each of those question groups, there will be elements that satisfy what has been dictated by the state and tailored plan requirements and implementation. And some examples are listed there below of what those elements are inclusive of, but not all inclusive. As I mentioned before, it's pretty extensive, but I wanted to give everybody an idea of the areas that will be assessed for in all of our members as they come into the tailored plan, which, for example, is immediate care needs, their social determinants of health, their ADLs and IADLs, their functional needs, falls, behavioral health diagnosis, and also then introducing the physical health diagnoses, which is important to the integration of what tailored plan model is in looking at the whole person and providing care and care coordination to the whole person. So some of the physical health areas or elements that you'll see here are related to bladder and bowel, skin integrity, preventative health, medications, pain, nutrition, and swallowing. So there are just some examples there for everyone to see that will satisfy those elements. Next slide. So the CMCA is meant to reinforce whole person centered care, and also assist with the development of care plans, and also the care coordination efforts that will go along with that. So areas of concern that are identified in the assessment are going to help us with developing a care plan for our member that's specific to their needs and specific to anything that is triggered by utilizing the assessment. And those groups, those question groups that satisfy the elements that I mentioned on the previous slide, those question groups are going to trigger pop-ups, nurse alerts, business actions, secondary and tertiary question groups that are going to take it in more in depth into that area. So we can really dig into what may be of concern depending on how the question is answered. And it's going to also populate care plan templates for us to build directly from that assessment. Next slide. So within those care plans, the assessor will have the ability, again, to trigger those care plan templates from those question groups where areas of concern have been identified. And that's going to guide them to address those through identifying the problem, goals that the member also participates in creating, and then barriers to the problem and meeting those goals, as well as listing out the interventions that will be necessary to assist that member. Next slide. So the current status of this build is that we are coming to the conclusion of the adult assessment build or completion within GIVA. The process has been, as Z Omega has taken the elements that are required for tailored plan implementation and inventoried against the content that already exists out of the box within their system. We have now conducted careful reviews that have crossed over 2 levels of internal work groups to review that content, to advise of and provide feedback to Z Omega of any additional needs, and to determine whether or not it satisfies the requirement for us. And so that adult assessment is also found in our GIVA sandbox, which allows us to review it as it will look in real time and give us a greater working visual of the product, and also get a feel for what it's going to be like to complete that assessment with a member. So the next phase will be that Z Omega will be introducing age-specific question groups related to pediatrics to the foundation of the adult assessment, because a great deal of those questions cross both age groups. But then again, there are specifics to children, and that will then bring us to the conclusion and the completion of our child assessment build over the next probably 4 weeks. Next slide. If anyone has any questions related to our care management comprehensive assessment that will be a part of our medical record platform in GIVA, please let me know.
This is Kathy Stevenson. It looks we've had several questions come in. I believe they mostly pertain to Sarah and Brian's presentation. Do you want to hold those to the end or go back?
Let's just keep going, and we can get back, because I think some of them are Sarah, Brian, network questions.
And as people process this information, maybe there will be a delay in any questions that come in regarding the assessment. So maybe we'll have an opportunity at the end. Thank you, everyone.
Great. Thanks, Christine. And again, this is Kathy Downs. So just following up, you guys are asking some really great questions. So we will try to get to a lot of those when we get to the network piece of the presentation. And if not, we will be able to answer those questions later. All right, so we'll go to the next one. Kate is going to talk about the tailored plan care management assignment. Kate.
Hey, hi everybody. I'm Kate Peterson. I'm a network project manager in our provider network department. And so looks like we've got a pretty full house. And thanks to a lot of you I see that did attend orientation this morning for provider-led care management. And so I'm going to actually bump it to Allison Reber here in a second, and she's going to talk about the assignment piece of this. I'm just going to give you some broad updates. So just to kind of recap where we are in developing provider-led care management, first of all, back to the state's overall plan was that in 4 years incrementally, we'd have 80% of the care management being provided by providers. And so to get us there, it was going to take some work with us and our network and us learning. And as you heard Christine, we're building out the comprehensive assessment. So where are we at this point in the provider-led journey? Well, after a couple of years of working with McSilver Institute, they're out of NYU and have done this work in some other states. We actually have done a bunch of training, and we've been offering monthly learning collaboratives, and our learning collaboratives have been really good. We actually focus on different subjects related to care management. We've had CIN presentations, as several of our agencies had lots of questions about CINs. And so we really have learned a lot about the models we're looking at, and a lot about providing whole health care. So a couple of things you want to know moving forward, and go to the next slide. I'm sorry, guys, I'm just talking and I'm not telling you to move. So go to the next.
We were just going to ask you about that, Kate.
Yeah, sorry, I'm just talking because I do that. All right, let me just, one last thing on this slide was we are going to allow the use of our care management platform. We have a provider portal, and it is the Omega Jiva, as you heard a little bit earlier. And we believe for a nominal fee or possibly free that those agencies that become certified to be care management agencies, then they would have the option of using our platform, which for those of you who've looked at the costs, they're quite expensive. So that may be an option for some agencies that could be more cost effective. Okay, next slide. So a couple other specific updates. We launched a care management pilot with Monarch, who was awarded the pilot through an RFP process. And they actually in Wake County have a team of 3 care managers and a peer working with an adult mental health and SUD population. Right now, there's about 78 members or so active in that CM pilot. And again, at this point, there's been 1 round of applications from the state to apply to become care management agencies. And this is a process by which you do desk reviews. They actually are having technical assistance to all the agencies that pass the first desk review with Mountain AHAC. And then you would have to be MCQA certified. And so there's after the first round of applications, there's in our catchment, including Orange and Mecklenburg, 31 organizations applied and passed the desk review. But that also includes 86 total sites in our area. So, and the second round of applications, and I see somebody popping up there, can providers still apply? The second round of applications is due September 30th. So that may be too quick to pull up applying if you haven't been preparing, because it's a pretty extensive application. There's a lot of technological expertise and thought that needs to be really given in these applications. So I will tell you that at this point, we don't know of the next date. There has been discussion at the state level that they would add some application deadlines after this second round. We just don't have any of that information at this point. And quite honestly, I suspect they're waiting to see what the needs are based on who actually gets entirely through the certification process. So that's really the update from where we are. We have a learning collaborative underway that meets monthly, and we're going to continue that throughout the process. And so just wanted to let you know about it. I'm going to boot it to Allison.
Good afternoon. I'm Allison Reber. I'm Senior Director of Healthcare Integration, and I was going to talk about care management assignment. There was a question as Kate was finishing about where do you access application information? The state has a care management page, and perhaps we can send that out, or put it in the prompts, but applications are made to the state, not to the LME MCOs, and it's the state doing the certification. So I'm going to apologize in advance. I'm having work done on my house and they're drilling into walls. So I honestly don't know how good the sound quality is going to be, but periodically there's the sound of them cutting into the walls. So at any rate, all members, all tailored plan members with Medicaid are eligible, continuously eligible for tailored plan care management. There are some exceptions, and that is people in ICF services, ACT services, people receiving high fidelity wraparound, or children ages 0 to 5 who are in the care management for at-risk children program. And the reason that these are exceptions is there is a consideration that these services and programs duplicate tailored plan care management. Members can choose to opt out, and they can choose to opt back in, and that can happen at any time. Next slide, please. So I'm going to talk a little bit about the Medicaid C waivers, innovations and TBI waiver, because those are special. Because of the federal requirements about conflict-free care management for people receiving HCBS services, how you assign people who are in these waivers is different than for other services. So the state has said that if a person is enrolled in the innovations or TBI waiver and has an existing relationship with a care manager, which currently those existing relationships are at the LME MCO, if that care manager meets the tailored care management qualifications and training requirements, and if that, care manager is employed by the tailored plan, then we need to give that individual the option of choosing their previous care manager. Next slide, please. For people who are not in the HCBS or waiver services and not receiving those duplicative services we talked about, we're using an assignment algorithm that we've developed, and we've developed an algorithm that is based on risk stratification and current connection to providers, so that people stay with their provider as a CMA organization as much as possible. We are required to assign at least 30% of all eligible members to provider-led care management in the first year, but we are pushing, and our goal is to have 50% of members assigned to provider-led care management in the first year. By year 4, we are required by year four, we are required to have 80% in provider-led care management. And members can choose to change their care management agency at least twice a year for any reason at all, and at any time with cause. And there is a lengthy list of reasons with cause. Next slide, please. So our algorithm looks at the following thing. We start with risk stratification. What are the predominant health risks? Are they on the behavioral side or physical health side? There are different kinds of care. Care management is provided by three kinds of organizations. It can be provided by the LME-MCO. It can be provided by a care management agency, which is a behavioral health agency who is certified as a care management agency, or it can be provided by an AMH Plus, which is a primary care practice that has certified as, have to be at least tier 3 advanced medical home, and it has now certified as an AMH Plus for the tailored plan services. So the goal is to put people with serious physical health in a setting where that can be managed, which is more likely to be primary care, and to put people in with predominant behavioral health risks in with providers who with behavioral health specialty. We are also looking at the current and historical connection to providers. So we are working to send people to the provider with whom they are already working. Next slide, please. We are also required to look at current capacity. So we will be having a system for you to be able to let us know your ability to accept referrals, and it will be important to keep that updated. There are very strict timelines about engaging with folks, so these need to be current capacity to take a new referral. And then we will also be looking at accessibility through geo-access to make sure that it's within reasonable distance, because this is a community service. There was a question that came through the chat about how are we going to assign? This is how we are going to assign, and it's actually pretty much in this order. It is in this order. This is how the algorithm works. And what's most key is the behavioral physical health needs and current connection to providers. Somebody also put in a question about what's a service integrity coordinator, and that might be best answered by Chris, because that's an internal title. Are there any other questions?
There were, I think, a few other questions based on your and Kate's presentation, Allison. Let's see. Somebody asked, what if they choose not to be a care management or do care management?
And that, I think that's an agency decision, and certainly there will be agencies that won't do care management. Right. And you will operate like you do. However, there will be a care manager assigned that you will coordinate care, particularly in physical health care and behavioral health care and social determinants. They'll be coordinating that care with you, but that's different than your treatment programs.
All right. Thank you. And then there's a question about where to access the application. Of course, we can look for that. What is information for the Learning Collaborative?
Just if you're interested, just email me. And my email's kpeterson@alliancehealthplan.org.
All right, thank you. And then there's a question, are providers able to make corrections and resubmit their response to the state if they do not pass the desk review?
I think that's probably a question best answered by the state.
Yeah.
I honestly don't know the answer to that, Ally.
I don't either. The certification process is a state process.
And then Allison, you addressed the question about how Alliance will refer folks to CMAs. Was there somebody on the call who wanted to field the question about the service integrity consultant within Innovations, what that is?
I actually did respond to Betsy directly.
Okay.
And so I don't know if the group would like to hear the response, but the service integrity consultant is an individual that works on the team in collaboration with the care navigator to assist in the provider monitorings.
All right, thank you. Oh, let's see. And then,
And I think Elizabeth Caldwell put in the application that website about where you can access information on care management in the application. So thank you.
I think those are the questions specific to care management. We still have a lot of questions, like I mentioned, about other things.
Yep. All right, great. So I'm going to go ahead and turn this next one over to Donna Stevenson, and she's going to talk about practice transformation support.
Good afternoon, everyone. I'm Donna Stevenson. I'm the Senior Director of Payer and Practice Transformation here at Alliance. This is a new position that Alliance created, and I'm building a team, particularly to work with all the agencies on two primary things: value-based contracting and becoming care management agencies. So I think it's a good thing I came right after Allison and the question about finding things for the app and stuff. So if you'll go to the next slide. I just want to let you know the support that myself and my team, who's one person, Micah Jeter at this point, but I am onboarding other practice transformation specialists. What we provide is I do have a practice transformation presentation. If anyone is interested in it, my email is going to come up in a minute. Just let me know and we'll go through what practice transformation is, how we go about doing it, what's the point of it, including working with your agencies to do gaps analysis. This gaps analysis isn't to be confused with the one that AHEC will send you if you've already become a CMA agency. Although if you compare the two, there are quite a few overlaps. So we also provide that technical assistance of working with you if you have questions on the AHEC gaps analysis, and we provide technical assistance with your care management agency application. We also work to review your data for 7-day hospital follow-up and other HEDIS measures that you will be accountable for as we move into the tailored plan. Next slide, please. And as I said earlier, my contact information, if you want, need, or feel like your agency could use any of these services or have questions, is dstevenson@alliancehealthplan.org. Thank you. Oh, I guess I should say, are there any questions?
None in the chat so far, Donna.
Thanks, Kathy.
All right, Matt, we'll put it over to you. Matt Ruppel is going to talk about fraud, waste, and abuse.
Good afternoon, everyone. My name is Matt Ruppel, and I'm hoping that you can see my screen. Is the slide showing correctly?
It is.
Okay, great. Thanks, Kathy. My name is Matt Ruppel. I'm the Senior Director of Program Integrity for Alliance Health. And today I'd like to share some information with you about fraud, waste, and abuse in healthcare. So I'm going to start with a brief video. It's about 5 minutes long, talking about fraud, waste, and abuse.
Have you ever been in a situation where you thought that maybe unnecessary medical treatments were being prescribed for patients by a provider, or even that patients were being billed for treatments that were never administered? This kind of suspicion can arise regularly in our business, and it can be difficult to know what to do. Imagine you are reviewing claims and notice that one provider appears to be prescribing a particular lab test for an unusually large number of patients. The tests are covered, the forms seem okay, and none of your colleagues have raised concerns in the past. Do you report this to your supervisor or fraud department, even though no one else seems concerned, and possibly stir up trouble for the provider for no reason? Or do you ignore it, knowing that there could be something illegal happening? It can seem as though there is no easy answer. The good news is that by the end of this brief video, you'll have the tools to confidently make the best choice in these situations. You'll make the right choices for both yourself and for the company, and feel a whole lot better in the process. The first step to avoiding healthcare fraud, waste, and abuse is being able to identify what they are. Fraud is any activity defined by an intent to deceive on the part of a patient, a provider or supplier, a third-party biller, or even a payer, with the purpose of receiving an improper benefit. Abuse, which can be very similar to fraud, occurs when a provider's practices are not consistent with sound fiscal, business, or medical practices, but unlike fraud, may not involve acts that are done intentionally. Waste, meanwhile, occurs from practices that result in unnecessary costs. For example, when a provider prescribes services that are not medically necessary. Some common examples of fraud, waste, and abuse include billing for services that have not actually been provided, misrepresenting services that have been provided, ordering tests that are not medically necessary, unbundling claims, or providing separate bills for procedures that should be covered by a single fee, double billing, or charging more than once for the same service, miscoding and upcoding, or using the wrong code for a procedure, either through carelessness or to charge for a higher-priced procedure that wasn't performed. Fraud, waste, and abuse are illegal under many different laws, and patients, providers and suppliers, and payers can be prosecuted for violating them. Thus, we must each take responsibility for actively participating in detection and prevention of fraud, waste, and abuse. It is therefore critical for each of us to be able to recognize some common signs. For example, when reviewing claims, do you see treatments or tests that are inappropriate for the diagnostic codes provided? Are there multiple procedures that appear to be part of a single treatment? Does a claim include misspelled or incorrect medical terminology? This may be evidence of falsification or tampering. Does a party consistently submit copies instead of originals? Does the provider and patient handwriting appear to be the same? Did the patient's diagnostic code change shortly before a benefit for treatment of the first diagnosis expired? Are there claims for extensive treatments for minor illness or injury? And are you seeing high-dollar claims shortly before coverage ends? By now, you should know how to identify fraud, waste, and abuse, and to be on the lookout for the signs. If ever you suspect this is occurring, do not be concerned about whether it is fraud, waste, or abuse, and do not wait. You must immediately report the situation to your supervisor or to our compliance or fraud department. They will investigate and make the proper determination. Getting back to the example of the provider who appears to be ordering an unusual number of lab tests for his patients, it is probably pretty clear by now that you need to report this situation. It may be that nothing irregular is occurring, but reporting it promptly will ensure that we can properly investigate the issue. By reporting the issue, you are not only helping the company, but you are taking a stand against fraud, waste, and abuse that cost taxpayers tens of billions of dollars every year. Now, doesn't that make you feel better already? If you have questions about helping to detect and prevent fraud, waste, and abuse, please contact our compliance or fraud department. We're here to help.
Okay, so we heard quite a few things in that video. Can you all still hear me? Just want to make sure.
Yep.
Okay, thanks, Kathy. So you heard a lot of examples there where it talks about fraud, waste, and abuse, and there's a lot of overlap. And as you can see on this spectrum here, you can see where they overlap. And as you move from left to right, you go from more like errors to bad practices to intentional acts. What might be waste in one case could very well be fraud in another. So I'd like to just kind of go through a few examples as you can see them laid out across the screen here. So just to kind of reiterate what was shared in the video, waste is the misuse underutilization or overutilization of services or other inappropriate billing or medical practices that add to healthcare costs, or unexplained variation in care that results in no discernible differences in health or patient outcomes. It is typically not intentional. It's typically an error. So the example that I have here is duplicate claims. So perhaps everything about that claim is the same. Maybe the provider submitted it twice and there was an intent to replace the first one because of an error in that claim, and then they both pay, resulting in an overpayment to that provider. So that would be an example of an error, and that would be wasteful. Next example would be inappropriate frequency in behavioral health. It could be overutilization, frequent visits 3 times weekly for outpatient therapy when there's really no discernible difference in the outcome for the member than if that person was seen 1 time a week or 1 time or every other week, something less than 3 times weekly. We do see this quite a bit in our investigations. And then moving over to abuse, which are practices that are inconsistent with sound fiscal, business, or medical practices, resulting in unnecessary costs to the Medicaid program, or reimbursement for services that are not medically necessary that fail to meet professionally recognized standards for healthcare. The examples I have here, and you heard this in the video, unbundling. So one example of unbundling would be taking the doctor part of an ACT service and billing for that separately when the ACT services are paid for as a bundled service. It includes everything, including the doctor. Unbundling can also apply to group therapy, taking each member that was in that group and billing for those as individual. That would be an unbundling of a group therapy code. Upcoding, which is providing services for a duration or level of intensity that does not justify the code billed. So that could be using a higher code in E&M or billing for a longer duration of an outpatient therapy visit. And then moving into fraud. So fraud is an intentional deception or misrepresentation made by a person with the knowledge that the deception could result in some unauthorized benefit to himself or some other person. Estimates from the National Healthcare Anti-Fraud Association puts the loss in fraud in the billions of dollars every year, billions with a B. About 10% of costs are generally associated or accounted to by fraud. So the examples here, kickbacks, which is covered by the anti-kickback statute. So offering or accepting any kind of payment in return for a referral, for inducing a referral, for purchasing, leasing, ordering, arranging, or recommending goods, item, or services for which payment can be made under Medicaid. Penalties associated with this. So any person that is knowingly and willingly engaging in kickbacks will be found guilty of a felony, can be fined up to $25,000 and or imprisoned up to 5 years for each violation. So each time can result in that. In addition, that person may also be in violation of the False Claims Act because any claim that is submitted as a result of a kickback is a violation of the False Claims Act. And then lastly, we have false claims, knowingly presenting or causing to be presented a false or fraudulent claim, knowingly using a false record or statement to obtain payment on a false claim, engaging in a conspiracy to defraud the government by improper submission of false claim. Civil penalties, because this has civil and criminal elements. Civil penalties include fines up to $11,000 per violation, triple the damages that are caused by that claim, and then cost of any civil action brought to recover. So any costs on the part of the government to recover that money would be on the perpetrator. And then criminal penalties include imprisonment of up to 5 years and a fine of up to $250,000, and then an exclusion from participation in federal programs for a period of time. So you wouldn't be able to participate in the Medicaid program or any other government program from that point forward. So then, what do we do if there's if you see this or one of your employees sees this, what should they be expected to do? It's not a matter of trying to figure out if it's fraud, waste, or abuse. That requires an investigation. This is something that the Special Investigations Unit Alliance would look into. So the first 2 numbers here, you can contact us directly. So the first one is the Alliance Confidential Fraud and Abuse line. So that is operated by a third party. We work with a vendor that operates that. It can be called 24 hours a day. And you can choose to be completely anonymous. You do not have to give a name. And that information will be collected and then submitted to us by that third party. And then we can stay in contact. There's a way to communicate. So if you do call, you would be given a code that you could then check back in a couple of days and get access to any information that we might submit. The information that we'd want to know about the allegation is the who, what, where, when type of information, who did it and what else do you know about it. But sometimes we get these allegations, we do want to follow up and get some more clarifying information. So That's why it's nice to be able to communicate. If you choose not to remain anonymous, you can definitely give your name and contact information. We can contact you directly. You can call us directly at that second number there. That's the General Alliance number. You can call and ask to speak with somebody in the Program Integrity Department. And then the remaining numbers here are not Alliance numbers. You have the North Carolina Medicaid Fraud, Waste, and Program Abuse tip line. You can call that number there. The Federal Office Inspector General Fraud line, the NC State Auditor Waste line, and then last, you have the Medicaid Investigations Division, which is that's part of the Department of Justice. They will investigate allegations of Medicaid fraud. They might refer that down to the NC Medicaid level, and they might then distribute it to us. And just quickly going back to contacting Alliance, we have measures in place to protect reporters of suspected fraud, to protect those identities. They're known as whistleblower protections. We will do everything we can to protect that information. The only time we wouldn't be able to protect it is if it was under court order. So if the information was provided and then we were compelled by a court order to release that information, we would have to. And then the next slide is just, you have my contact information there. Feel free to reach out to me by phone or email. I'm happy to answer any questions. And if there's any questions that come up today, I'll be here to answer them.
Matt, there was one question in the chat. Could you speak to, with regard to the hotlines, the question was, do these also relate to reporting abuse, quote unquote, of a personal nature, not a financial nature?
So like an abuse of a member or something like that? Is that the question?
That's how I'm interpreting it.
Okay.
There's some kind of, I'm assuming some type of mistreatment or possible abuse of a person.
So that last slide, where the Medicaid Investigation Division, they will investigate that. So that would be a good number to contact for that. But allegation of abuse of a member would be better reported to our Quality Management Department by contacting the number there, that the second number I listed, and asking to report a complaint.
All right. Is that it for questions from
I believe
Matt?
that's it for Matt. Thank you.
Okay, great.
Thank you.
All right, thanks, Matt. Appreciate it. So we're going to go ahead and Larissa Witt. Larissa, I'm going to have you go ahead and introduce yourself, and she's going to talk about the Hope for NC overview and I think some other things.
All right. Well, good afternoon, everyone. Thank you so much for this opportunity to talk about Hope for North Carolina and the trainings that Alliance provides. Hope for North Carolina is a statewide initiative that's funded through FEMA to help with those who are affected by COVID. Yes, we are still talking about COVID a year and a half later. And we understand that there's a lot of people who are still reeling from the effects, both financially, emotionally, physically, and there is hope out there. And so Alliance partners with the state for this project. And it is actually covered in all 100 counties. All 7 MCOs are part of this process. You can call 7 days a week, 24 hours a day. Your members can, you can, to get the help and support you might need. It's confidential. It's just giving the resources and the emotional support for anyone who just needs a little bit of help. Sometimes it can get pretty lonely and overwhelming in the middle of the night, and there's somebody there to help you. There's hope on the line. And the next slide, please. And then there is Hope for Healers. So this is really for our providers, our first responders, childcare workers, teachers. The state of North Carolina has partnered with the Psychological Foundation to provide the same kind of crisis counseling for people who are in the helping profession. And we would encourage you to reach out to those if you find you just need to talk to somebody. Once again, it's confidential, and we're here to help you. All right, next, please. Next slide. So some of you may have already seen this. The scope, it's on managing stress, because we do know we're all under stress. And we know the need is great. Alliance alone has had individual contacts with about 23,000 people since COVID began, and we've given out over 300,000 pieces of material. We're connected with all the vaccine sites and the the medical places and out in the community. So we know people need support. And these are some of the ways that you can take care of yourself because you're a caregiver. And we often know that caregivers don't always take care of themselves. Next, please. So Alliance also has, we have our own free trainings that we offer regularly. So we have a whole training department, our community outreach and education team, and they are providing trainings that are from a lot of different topics. One of our most popular is the mental health first aid. We offer that training. These are, most of our trainings are free. That particular one costs because of the book, but most of the others are free. If you've missed any of our trainings, we do have them listed on our YouTube channel, and you'll get this PowerPoint, and it's embedded in that, in this website. And we have a variety of trainings that are not only about healthcare, like so how to manage diabetes. So it's not just for the mental health side, it's also for behavioral, for primary care, smoking cessation, all kinds of trainings that are free for you and your members. All right, next, please. Oh, this is an older slide. Sorry. We do have a better at home training. So we know that people are better at home. We know that housing is a social driver of health. And I am actually the supportive housing manager for Alliance. And we have multiple trainings in the bed called under the better at home umbrella. So we have weekly trainings where we're really helping our providers understand not only are we addressing the behavioral health concerns, but oftentimes our providers know a lot about, oftentimes they know a lot about behavioral health, but tenancy can be a little tricky for them. And so we have this whole array of trainings, and it's also on YouTube, on our YouTube channels for past trainings. And these are trainings that are really about how to read a lease, how to manage the, how to get, write a reasonable accommodation for one of your members, how to talk to a landlord, what you should be saying, what you shouldn't be saying, the rights and responsibilities, how to manage disputes within tenancy. So all the things that our members may be facing, and they need a little more support so that they don't separate from housing, because what we know is that people are better at home. We want to keep them in housing. We also offer other trainings. We have what's called Independent Living Initiative. So especially for those in Mecklenburg who's on the line today, we have a program where we actually provide rapid, so temporary financial assistance for people, for members who are in our enhanced services like ACT services and CST services, so that they can stay in housing. We partner with the Corporation for Supportive Housing, and that to provide office hours. And then every other week we offer a question and answer time where we have providers just call in, and our team, my team, is on the call and just answering questions about housing search and navigation. What is a targeted unit? What is Section 8? What's a mainstream? All those really nuanced things that many people need to know to keep your people in housing. And next, please. I think that might be it. Okay, so this is how you access our trainings. So right here is our training site. You can go up here and look to the training, and these are listed on our calendar. You just search for trainings, and those are listed. So you can find out where to get connected to all of our trainings. And next, please. And if you've missed it, it's still, you can scan with your phone camera and you can see our annual report and see all the wonderful things that Alliance have done in 2020, and also kind of some of the things we're looking to achieve in 2021. So, all right. So if you miss it, there's your chance. Next, please. That's and so James Osborne is the Director of Community Education and Outreach. That's his contact information. And my contact information is lwitt at WITT, no H, at Alliance Health Plan. So I'm just pitch hitting for him. So thank you so much. Have a great day. If there's any questions, please let me know.
Great. Thank you very much
Larissa.
for Larissa.
All right.
I'm sorry.
No, that's all right. There was one question about how does this fall into CST as we are doing that. So I'm not sure which part of your talk they might have been speaking to, but you just want to talk real quickly about.
Kathy, I
specifically about
I got an answer to that. She was asking about tenancy through TCL and how to
Okay.
work that into CST services. I guess is around the housing, the tenancy.
Sure.
Yeah, so transition to community living, our people are oftentimes associated, are receiving CST services and ACT services. And we have a whole training on how to access TCLI and what TCLI is. We also have a training on the Olmsted settlement specifically, because it is more than a mandate. I don't know if I'm actually answering your question, but you can email me and I can talk to you further about those processes if you'd like. Elwitt@Alliance Health Plan. Thank you.
Great. All right. Well, thank you very much, Larissa. We're going to go to someone that wasn't outlined specifically on the agenda, but technically part of the provider network updates is Christina Phillips is going to give us a brief update on EVV.
Thanks, Kathy. Thank you for inviting us to talk just real briefly here about EVV. My name is Christina Phillips. I'm one of the supervisors here in Provider Networks. Hope everybody's doing well. Next slide, please. So just for folks to know here real simply, EVV mandate is impacting TBI waiver, innovations waiver, and select B3 services. So for a lot of providers, EVV is not required. Those of you who are EVV providers, we've been working with you for the past 6-7 months to get systems set up. We've been working with HHA and just wanted to give a brief update where things stand right now. Next slide. So as folks know, EVV did go live per DHHS. We were live September 1st, 12:01 a.m. And this does apply to dates of services, not claim dates. So I just wanted to clarify that. And we had a few questions come in around that. So it is date of service, not claims dates. Next slide. So what we've recognized here at Alliance is that operationalizing EVV systems has been complex for everybody. We have been in direct weekly collaboration, internal meetings with HHAX Client Success Team Director, Madeline. She's been wonderful to work with. We have set up an EVV help desk specifically for our EVV providers, and we are triaging and responding to all the EVV technical assistance questions that are coming in right now. We have hired an EVV help desk specialist, and I just wanted to introduce her briefly so you can see a face to a name. We were welcoming Amanda Smith, and Amanda is currently right now in training. So welcome, Amanda. Thank you we're excited to have you on board.
I'm happy to be here.
So we do recognize that each provider query is very complex. And so what we're asking is that all EVV questions do funnel through the EVV help desk. If we can streamline it, that is really helpful. We are tracking each query. And we recognize that each query is unique and has many nuances to it. So we are working not only with our internal teams, but also with our HHA support team as well. Next slide. We wanted this slide to be available to everybody to see that there is technical support available at this time. We do have a EVV help desk, like I just said, set up. That right there is the direct email address to the help desk. We also have an EVV information page that has lots of different resources on there, specific to HHA and specific to Alliance. Also, if you are experiencing difficulties with your portals, with your EVV portals, we are asking that you first go to ncsupport@hhaexchange.com. If you are you have a third-party EVV system set up, we are asking that you go to the EDI support@hhaexchange.com. That's for EDI providers who are using that third-party vendor. HHA also does have a live help desk. That is the phone number listed right there. We're encouraging if you need one-on-one assistance, need some additional support with your portal, to call that help desk. If you are emailing us with a specific query, please make sure if you've already contacted HHA that you include that ticket number, because that will help us reach out to HHA and help expedite some of your questions with them. If you're not getting a response with that ticket and you want some follow-up, we're more than happy to help with follow-up. So just wanted folks to know we are here to help. We're here to support. It is complex, and we recognize that each query is individual and unique. So thank you. Thank you, Kathy.
Great. Was there any questions, Kathy?
There was one question about where to go to complete the EVV application process. Is that at the website you've noted on the slide, Christina?
We
The
can
page
help
on
that
our
provider
website?
has- Yeah, so I would actually send that query directly to provider EVV, that our help desk. We will assist you directly with your setup and how to connect with HHA.
All right, thank you. I think that's the only EVV question.
Okay, great. So we'll go to the next section, which is around provider network updates and provider network operations update. If we can go to the next slide. And what we wanted to share with folks is the provider network department has gone through some changes with staff. And so we did want to provide some information about who's with the team at this point and how to get up with them. So we do have a new senior vice president with Provider Network, and it's Sean Mazik. And I know Sean is on. I know he was having some technical difficulty, but we're very excited to have Sean. Sean, are you able to talk, or I'm guessing not? Is he comes, with some managed care experience from some of the bigger plans, particularly also around with physical health and contracting. So we're very excited to have Sean join us and be able to bring us some other perspective and experience to the team. And myself, I don't actually know. I think I might have jumped in and didn't ever introduce myself. For those of you that don't know me, my name is Kathy Estes Downs, and I am the Senior Director of Provider Network Operations. And I've been with Alliance for a while. And before that, I was out in the provider world for a long, long time. So really feel like I have a good appreciation of the day-to-day operation stuff that providers go through. And then with our team, we have Kathy Stevenson, who you've heard. She's, I feel like I'm doing a band backup, at the end of the show. But she is our network development specialist, and Christina Phillips, who you just heard, she is another one of our network development supervisors. And Kathy Stevenson is a supervisor. I might have just said a specialist. And then we have our provider network development staff, and we have Bill Young. Bill's been and Todd, Bill, Todd, Melissa, and Ron have been with Alliance for several years. And some have even been with Alliance prior to Alliance days with the Durham Center. And we have 4 new staff that joined our network operations team, and that is Larry Campbell, Jalissa Cole, Jill Osborne, and Andrea Swink. And Kathy and Christina, I didn't know if you wanted to add anything for the new staff, or if you wanted them to say anything.
Oh, I just thought it might be nice to ask them to at least say hello so people can see their smiling faces. Jalissa Cole joined us August 23rd. Jalissa, do you want to say hello? All right, maybe she's not right there. Jill Osborne joined us this Monday, so day 3. You want to say hello, Jill?
Hi, good afternoon. I'm Jill. I'm excited to be here. Can't wait to get started working with folks.
Thanks. And then Larry Campbell also joined us Monday, day 3.
Hi, everybody. How are you doing? I'm glad to be here.
Thank you. And then I'll turn it over to Christina.
Sure. And we have Andy Swink, Andrea, but she goes by Andy. And Andy will get a chance to meet a lot of our TBI waiver providers. She'll be helping us build out that network a little bit more. Welcome.
Hey, I'm Andy, not Jill, even though it says Jill.
That's Andy.
That's funny. Well, great. And we also, and I apologize, I forgot Amanda on with our EVV help desk person. So Amanda Smith joined us also, which Christina already did her introductions. And we also have Rachel Porter, and the provider network team, now has some wonderful help with some administrative support, which will be helpful. So Rachel Porter joined our team for that. So any of these folks you may hear from, get emails from, wanted to at least get the names out there as well as their contact information. Go ahead, you can go to the next slide. And because we've got staff that are just coming on, and we're really looking at them with the realignment with MEC and Orange, really having to look at how we're assigning providers. So please know that we're going to be in the process of doing that. You will be able to find that assignment. We have our current one up there, and we'll do an updated one once we finalize that. But if you ever have a question as to who your provider network person is, or want to talk to a specialist, you can always email our help desk, and they will go ahead and they'll assist you with getting to or hearing back from somebody that will help you. Okay, next slide. All right. I did not do this slide very prettily. So I did want to talk about just a little bit about what we're doing as far as with the Cardinal realignment in our enrollment process. As Brian talked about, we will be aligning with those two areas effective December 15th, and we're working really hard at trying to get things done and in place. And again, the Alliance Network's open to the providers that are currently serving Mecklenburg and Orange, that have the contracts in good standing and meet all the rules. And just want to, the first step is that there's a contracting process, and we still need to get certain information. And so we do have two different packets, for providers that aren't contracted. And we also have providers that are currently contracted with Alliance, but need to add some sites and services that are not currently in their Alliance contract. Next slide. So one of the things we want to make sure is, and I've been seeing, and I've been going through them, is that we're starting to see enrollment packets coming in, and really asking folks to get them in by the end of this month, because it is going to be, we do need to go in and verify all the NC tracks set up and get things set up. So we're asking for a September 30th that you submit all your packets. It doesn't mean that if you submit it after September 30th, that means that you won't be in our network. That's not true. It's just in order to help ensure that you guys have the contract and all of that by the go live date. And our goal is to have that even prior to the go live date. We may be reaching out to you guys as we're going through the packets, or as you guys that have been in this business a long time, there's nothing constant but change that we all deal with. So sometimes we hear of some different things that you may need to ask for, but we would reach out and ask you for any of that information. And then just included, you guys are aware that I'm thinking that since a lot of the Cardinal folks that are on the call, have signed up for our provider news. If you can go to the next slide, but we do have the alignment sort of landing page. One thing that I do want to share, so this is some new information. We had originally asked for the HCBS information about maybe sending the approval letters. We do not need the approval letters. If you've sent them, that's fine. But we are asking for you to send a spreadsheet of your HCBS site. So instead of sending the approval letters, just to include those sites. And then the other thing that we no longer have to ask providers to send to us is the credentialing approval letters or your contracts with Cardinal. So we've gotten some of our, sorry, my puppy started getting into something. We are receiving the information we need directly from Cardinal. So you will not need to submit a copy of your credentialing letter or your contract as part of the enrollment process. Again, if you have, that's fine, but just wanted to let folks know that based on some our recent contract amendment with the state, we don't need to have that information. So I hope that will be good information because I know people have been struggling a little bit with that. Next slide. Do I have a next slide? Okay. So also just reinforcing, we use Provider News as our way to communicate with providers. And we really strongly encourage folks to sign up for Provider News. You can sign up for daily or weekly notifications. If you sign up for the weekly, it's on Friday. You would then get all the notifications that came out throughout the week, or you can sign up for daily and you would get any updates that come daily would come to you. So that is the way that we would want to make sure that you guys stay in touch with us, because we do notify about changes in potential contract terms. There's a lot of different things that you would want to know that information. Next slide. Is that it? So the other thing we want to remember, and we know we're still in the process of some of the development assigning, but once you learn of who your network go-to person is to utilize them for questions that you have. But again, in the meantime, if there's questions that come up, you can certainly reach out to Provider Network, our help desk, and that they will be able to help you. I did forget to put in an important slide. So I do want to let folks know for our current Alliance providers is our COVID rates are going to extend through December 31st. So if there was a specific COVID rate that I believe was scheduled to Medicaid at this point, we should hear back about state funding Monday or early next week. But for Medicaid COVID rates that were expiring on October 31st, we are going to extend those through December 31st. So did want to let folks know that, and we'll put that out in a specific Provider News also. But we hope that's good news for folks. So please take that back to folks in your organization that should have that information. All right, so it sounds like we have some questions that we can try to answer. So Kathy, do you want to start, I guess, at the top, and we'll see what ones we can answer?
Sure. Yes, we have a lot of questions. Let's see. Well, an easy one. I know we're going to post the recording on the website. Will we also just post the slide deck?
Yes.
Okay, I thought so, but wanted to confirm. That was one question.
Yep.
Will there be another webinar closer to transition to go over in more depth authorization transitions and requirements?
Yes. So we actually are in the process of putting together some trainings that will happen mid-November that will be around authorizations, the benefit plan, the claims system. So I believe right now we've tentatively are looking at, I think it's November 17th and 18th And as soon as we get that firmed up, we will put that out in provider news on our training calendar. And we are also working with the Cardinal folks around including information in their provider communications that affect folks for realignment. So we would also forward that to them. So hopefully you would be able to find that information in a couple different venues.
All right, thank you. And let's see. When can new transportation providers get credentialed with Alliance?
So I'll have to take that one back because transportation, I know, is something that we have to have in place when we go for the tailored plan. So I would need to follow up with the team that's working on that.
Okay. And let's see. What if Alliance doesn't have the service we offer in Orange County on their benefit plan? For example, YP 780 group living.
So that's a good question, and I know it's causing a lot of different anxiety. So we have a group that is working with Cardinal around identifying what are those differences. You know, if there are some services, you know, particularly you were looking at that group living, you know, nothing is going to, group living is not going to stop for the Cardinal members at the time that we go live. So, you know, so I would say there's going to be a reconciliation. There may be some services that are really similar that we'll be able to identify that instead of having two separate of almost the same, we'll move it to within one. But we do have some teams that are working on that right now. But for those folks that with the group living, I do know that that's a concern. You know, that group living will continue. We'll be working with Cardinal, understanding their slot process. I know they have wait lists for that. As folks know, there's limited funding for that. So, you know, definitely folks that have current authorizations, and, you know, if through the next 3 months and you're working with Cardinal and, you know, that they've identified through their waiting list that someone that they choose to authorize someone, then we would still be honoring that.
Okay. And will the new HCBS assessments need to be completed, or will it transfer to Alliance?
We'll get some more clarification. Here's what I know. Is that we are working with the state on being able to have access to the HCBS portal. So we'll be able to get that. So I believe the answer is you don't have to do new assessments, that we will be getting access to those HCBS. I'm probably saying it wrong, assessments and all that information.
Okay. And if a current Alliance provider receives a referral for someone in Orange County, are they able to provide services, or do they need to request to have the new counties added to their contract?
So there's probably a lot of specifics. Let me get rid of my dog for a quick second. Sorry, guys. Somehow my 17 daughter came home from school and put all the dogs in the room with me. Okay. So I do apologize. So if you're an Alliance, so your Alliance contract does not change currently. So if if you're saying today you receive a referral for an Orange County member, so the transfer doesn't happen until December 15th. So it wouldn't be covered under your Alliance contract now. So I guess it's just understanding maybe a little bit more specific about what the circumstances. You know, are you talking about a Cardinal member coming to you now? Coming to you now, you'd still have to go through the Cardinal process. So maybe we can get some more details on that. If someone wants to put
Right.
more, whoever asked the question wants to add some more details in the chat, we can come back to it.
Okay, and let's see. There were a few questions about people who need members who need to transition or move from standard plan to tailored plan. And why is it taking so long, that they have people waiting for services that are needed? And so I'm assuming those might be questions more for the enrollment broker.
Yeah, so those would have to go through the enrollment broker. Well, I would encourage if, for Alliance folks, if you're still really struggling with that, to contact us and we can see, help with the specifics for you. I did see one of the chat questions around intensive in-home. Technically, the standard plans are supposed to still offer the benefits through EPSDT. So you may want to explore that with them. And that is supposed to help cover that transition time.
Right. Would you say to use the provider network?
Yeah. If there's
The help
a
desk
real
email?
specific, and if you're an Alliance, currently contracted Alliance, actually you know your network specialist, you could also reach out to your network specialist.
Okay. Let's see. Will Alliance add the licensed AFL homes to our contract, or will the provider need to make this request with the network?
So so we received a file from Cardinal. I'm assuming that this is a Cardinal provider. We received a file from Cardinal that shows all of the sites and services that each provider is currently contracted for. So each of the licensed AFLs should be on that list, and we would, that would be part of your contract with Alliance. The unlicensed AFLs, you would definitely, we're going to need that a spreadsheet, and because those would also be on your HCBS list. So we would, for the unlicensed ones, those would be on the spreadsheet, but for licensed, those are a specific site that should have come over from Cardinal.
Okay. And then what happens if a provider is in the process of acquiring residential services? And you might need more details about that.
So the general answer to that is, we are just, we really need to get the current contracts and providers and everything done before we start working on anything new. And we're going to be doing our needs and our gaps analysis to determine that. So just please hear that the first thing we're going to do is the things that are currently contracted with Cardinal, currently contracted and credentialed with Cardinal is what our priority is. And then we'll complete our needs and gaps, and we'll have mechanisms to be able for folks to be able to talk about other services that they potentially were in the process in, or if we've identified there's a need or a gap around looking for what those are.
Okay. When will the next meet and greets with current Cardinal providers be scheduled? They had heard there would be dates for October released soon.
Yes, so that's still being worked on. So again, we'll put that out in provider news as soon as that has been finalized.
Okay.
And I do believe those will be all virtual. This time will be virtual rather than the in-person.
Right. And then there was a question about individuals with enhanced services and needing to transition to tailored plan. Are there situations when that doesn't need to happen? It sounds like, of course, for kids under 21 with Medicaid, EPSDT would apply. as far as
Right.
the standard plans
As far
go.
as a tailored, and just remember, we're not a tailored plan yet.
Right.
You know, I think folks, I've been on a couple different calls today even, where I think people are confused about tailored plan, you know, that we're still a LME MCO. The tailored plan and some of those requirements and services don't go into effect till next July. So just remembering that.
And then let's see, we have to get through the Kate and Allison questions. Let's see. You talked about services and provider search. Next question, when will Alliance contact providers to have a meeting about the information needed for credentialing purposes?
So we are not having to do full credentialing. It'll be more about enrollment, that we will be reaching out to you as we're going through everybody's folders to determine what else we need to get you loaded into our system, provider directory, and claim system. So you will start, as we're going through that, we will be reaching out to you for any other additional information that we will need.
Okay. And then there was
I'm sorry. The enrollment
okay.
packets will give us a good start. There will be some additional things that we'll need, you know, for payments like EFT information and you know, more along those lines of what we will need.
And then are the tailored plans across the board, or are they for a specific client, such as someone receiving enhanced services?
Say that again.
Well, I think it's a question about the distinguishing between standard plans and tailored plans. So some people, of course, were deemed eligible for standard plans and or chose standard plans if they were able as of July 1. Tailored plans go into effect July 1 of 2022, but the LME MCOs are currently serving tailored plan eligible members.
Right.
So if that answers the question, or if it doesn't answer the question, you can add additional questions in the chat. And then there was a question, does Alliance provide free trainings for CEUs? I will say what I have.
Yeah, go ahead, Kathy.
I was just going to say, I know sometimes provider news announcements go out about trainings that Alliance offers in conjunction with one of the AHECs, and those sometimes have a very low cost. Like I've seen $5, $10. I don't know if you want to add anything to that, Kathy.
Yep. No, I think that's it. And then trainings that we do that may not necessarily be a CEU, but
Right.
some boards will count towards training as long as there's
Right.
certificates. You know, that you'd be eligible to get certificates. And as we're preparing for the tailored plan, we're also developing a more comprehensive training platform and system too. So when we know more about that, as we get closer to tailored plan, we'll definitely let folks know.
Right. And then can you speak to Alliance and how we handle IPRS or non-Medicaid contracts? There was just a question if we offer IPRS contracts.
So again, if it's, I don't know if this is an Orange County or not a Cardinal question. So if it is a Cardinal question, we are waiting to get information from Cardinal specific to around the state UCR and non-UCR contracts, so we can get our contracts out around that. For Alliance, at this point, it's a closed network for adding any additional sites and services. And that includes for state, because state, as folks are aware, there's very limited funding. So, we typically have limited contracts for that. And, at this point, unless there's been some additional funding identified and needs, we're not adding state-funded contracts for Alliance contracts. So just make sure that Cardinal folks are here, that if you currently have a state contract with Cardinal, that will transfer to us. We're just trying to figure out exactly all the specifics around that with Cardinal.
Okay. Next question, if we are a service provider that is already contracted with both Cardinal and Alliance for the same service codes, do we still need to submit an enrollment packet?
Yes. Yes, if there's different sites. If it's the same site and the same services, then no. But if it's probably more if it's a different site that you don't currently have in your contract, then you would have to submit an enrollment packet. But if everything is exactly the same, then you would not have to.
Okay.
Hey, Kathy, can I ask a question actually? Because I just wanted to clarify for Cardinal providers. I think we told them a little differently during the meet and greets last week. We told them that if they're currently contracted with Alliance, that they just need to submit the form to add sites and services to their contract. We did not need to do the full enrollment packet.
No, yeah, so you told them wrong. So we have, so on the website, there is a packet for currently contracted Alliance providers, and there's an enrollment packet for non-contracted providers, because we also need additional information for our provider directory and sites and specialties, and that's included in that currently contracted provider packet. Sorry.
All right, next question. Sounds like some clarification is needed. If you are a provider in Mecklenburg County, are you saying that if you're a provider in Mecklenburg County, that the only documentation you will need is the spreadsheet of HCBS sites?
So I need the enrollment packet. And if you do HCBS, if you have services that require HCBS, you would just, instead of sending the approval letter like we had originally asked in the contract, you would just have to, you could send the approval letter if you have it, or you could just send it on a spreadsheet, the different sites. Yeah.
Okay. And please repeat what you said about needing or not needing a credentialing approval letter if our staff serving Orange County are already credentialed with Alliance.
So we do not need the credentialing approval letter from Cardinal. And I put something out in Provider News today also about that.
Okay. Was there a review of the COVID rate? Want to repeat the update about the COVID rate?
Sure. So the Medicaid COVID rate is extending from, it was currently slated to end October 31st. It will continue through December 31st. And we will have an answer early next week as to what, if anything, what may or may not happen with extending for any state-funded COVID rates.
Okay. And let's see, did I understand Alliance would be opening offices in Charlotte and Chapel Hill? We are going to have a local presence in those counties.
Yes, that is my understanding.
Yes. Let's see, what is the status of Cumberland County providers receiving group living services for their clients? Are providers unable to receive this funding anymore?
So for group living, and it's been, we were just talking about this earlier, I think it's been about a year actually, for group living for 5,600 A's. Alliance has phased out that as a benefit for the folks in the Alliance catchment area currently. So if that is the request, that's not a benefit that we currently offer. If it's for a group living for a 5600C, you would need to talk to your care manager around, seeing what the availability is for funding for any of the 5600C types of situations. And that's more, just so if folks are clear, is the 5600As are more typically mental health, and the 5600Cs are the primary IDD.
Mm-hmm. And then a question about repeating what we said about standard plans with regard to intensive in-home services. And I think what you said basically was that the standard plans are required to follow EPSDT for youth with Medicaid under the age of 21. And so providers could contact the standard plans for kids with standard plans about the EPSDT process.
Yes.
Yeah. The ACS system does not allow an auth request to be submitted under EPSDT for clients that are in standard plans. So if we can't submit the request, how do we get a client authorized? I think that goes back to what I was just saying. You would actually have to go through the standard plan to request the authorization based on whatever their EPSDT process is.
And we are also, I know, working to have a communication that might outline a little bit more of exactly, around an authorization request that actually goes to the enrollment broker that would come to us. Because there could be times what we're hearing is that it does get, it's going to come to us, but it hasn't been updated on the file yet that comes to us. So I know they're working on that. So stay tuned to Provider News around some more communication helping with that situation.
Will there be another orientation for agencies like the one this morning?
Kate?
So let me be real clear. The one this morning was for care management. It was care management specific. And we did not plan to have more orientations for that, but you're welcome to email me and request the recording and we can get it to you.
So it was recorded.
Yes.
Okay, great. Next question. Is it correct that the HCBS application must be completed by September? I think that's part of the enrollment packet. So that
yeah, it's part of the packet that you would submit by the end of September. The HCBS, again, spreadsheet, whatever's easiest for your you as a provider to give us that information as to where your current HCBS sites.
Okay. And is the COVID rate for certain services only?
Yeah, so throughout, I think from March of 2020 to current, we have been putting out Provider News that specifically identified specific COVID rates for specific services. So all of that is in provider, past Provider News for that. And hopefully you would have been billing for that for the past, for the last year or so.
Yeah. So if we have questions, especially regarding the realignment after the meeting, and we already know who our network person is, can we email them or should we email the provider network email? You're welcome to email your network specialist.
Yep.
And then is there a network development specialist assigned to Novant Health in Meck County? Well, as it turns out, I handle hospital system contracts and have been in touch with Novant Health at, I guess, a hospital system level. But if there's something you think I can help you with, you're welcome to email me.
And Kathy's email was on that, one of the slides that had all of the names in the emails too.
And I'll type it in the chat.
Okay, all right.
And let's see. The information under the questions and answers section of the website for Mecklenburg providers states that providers are not required to complete the entire enrollment packet. True or false?
Can you say that one more time?
The information under the questions and answers section of the website for Mecklenburg providers states that providers are not required to complete the entire enrollment packet. True or false?
They would be required to complete the information that's in the packet as it's identified in the packet, with just knowing that today we updated, we just put out a provider news about they do not have to submit the credentialing approval letter, the contract, or the HCBS approval letters.
Okay. Oh gosh. Who is the network specialist for Mecklenburg? So there's not one specific specialist assigned to all of Mecklenburg, like Kathy, the other Kathy mentioned earlier. For provider network development, we've recently brought on 4 new team members, 3 of whom just started day before yesterday. And so one of the things that we'll be doing, as soon as we can, is to try to look at just assignments for our existing Alliance network providers. And then as we get direction from Kathy Downs about specific outreach to Mecklenburg and or Orange County providers, we will make those assignments. I think in the meantime, if you are a provider that's not already contracted with Alliance and you have a question, you can use that provider network at alliancehealthplan.org email address, and our help desk will forward that, and we'll ensure that somebody reaches out to you to offer assistance.
And just to give it a little bit of perspective, so as Kathy said, we've got 4 new folks that we've brought on in the last month, and we're going to be bringing on 4 more. So as we're trying to go through the process of what it will all look like mid-December, and there's still some unknowns. We're still just sort of figuring out exactly what that will look like. But you'll always be able to find somebody, again, like what Kathy said, the provider network, and a network person will get back to you if you're not currently assigned. But over the next couple months, again, with us onboarding ultimately 8 new staff since the end of August, there's just a lot of transition and really thinking about, sort of being as efficient and helpful as we can to be able to meet everybody's needs.
I think that's all the questions.
Okay, well, and I think we're right at the end. You guys asked some really good questions. And the other thing that we're looking at doing for the Cardinal realignment is also doing a couple of information sessions that would be real specific to a lot of the questions that you asked today. So we'll look at having a couple of those in October. So we'll put out those announcements of when those would be. So you'd be able to continue, because there'll be questions that come up that none of us are thinking of right now, or that you haven't thought about how something might impact what you're doing. So we will also have that forum set up too. Well, appreciate everybody on the line and taking the time. I know it's a lot. It's 2 hours is a big chunk. So just want to say thank you. And I think today was the first day of fall. So it's starting to cool down a little bit. So enjoy that. And we'll talk to you again next time. Thank you.